Integrated Care Board. Just want to start with an apology. We were due to meet in person today. Unfortunately, due to circumstances beyond our control, the venues to do that have not been available. So last week we had to take the decision to hold the meeting over Teams, and hopefully that has still enabled people who want to join the meeting to join. So in terms of just starting, just remind everybody joining the meeting today that Staffordshire and Stoke-on-Trent Integrated Care Board meetings are meetings in public. They are not public meetings. And the meeting is being recorded and will be available on the ICB website after the meeting. Questions from members of the public are invited at the end of the meeting on any item that the board has covered on its agenda today, and questions that have been submitted in advance via email will be addressed by me at the beginning of the meeting in a few moments, and we will make sure that we have colleagues on the call who will address those points. In terms of apologies for today's meeting, we've got Heather Johnson and Becky Scullion is representing Heather. So welcome, Becky, and thank you for that. Mike Lawton, Non-Executive Director, and Pat Flaherty from Staffordshire County Council. And I've been advised that John Rouse will be attending the meeting from Stoke-on-Trent City Council, but will have to step out for a short period at 1:30. So thank you for alerting me to that, John. I'd also like to begin by extending a really warm welcome to Dr. Joanna Chan. Jo is Primary Medical Service Partner Member and has started on the 1st of May, taking over from Jack. So Joanna, welcome and great to see you. We look forward to working with you going forward.
Thank you very much for that introduction, David. I'm delighted to be appointed as a GP partner member. For those that don't know me, I've been a GP in South Staffordshire for 20 years. I'm hoping to be able to give a meaningful GP perspective to the board, but thank you again.
Great, and thank you for that, Jo. We look forward to working with you, say, over the forthcoming months. At Enclosure 1, we have the Leadership Compact. And again, I just want to remind the board that the Leadership Compact is a very important document, and it's used at all meetings across the Integrated Care Board and Integrated Care System, and it guides the way that we conduct our business, and we'll return to that at the end of the meeting to review progress against that. Enclosure 2 is the Conflicts of Interest Register. Just pause for a moment. It is up to date, Paul, but I will just check if anybody has any conflict of interest on any item on the agenda today. If not, we will move to Enclosure 3, the minutes of the meeting that were held on the 20th of March. And if we could go through those for accuracy, I'd be grateful. Page 1, page 2, page 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 and 14. The board content to sign those off as an accurate reflection of our discussion. Thank you, and thank you, Lisa, for the production of those. On the action log, we have 2 items for today's meeting. Chris Eibel in the room. Chris, can I come to you first for the update on the digital?
Yeah, sure. Thanks very much, Chair. So I'm pleased to say that following that action being logged, I've had discussions, a brief discussion with our NED, Julie Holder, and also with the Health Informatics Service that actually run our Staffordshire and Stoke-on-Trent cybersecurity services. Following those meetings, we've instituted periodic formal reporting. So we've received the first report. Unfortunately, it wasn't in time to meet the deadline for the board papers, but I'm very happy to share those with the board immediately after this meeting. But in summary, I just wanted to re-stress the number of events, cyber events, that are happening on a monthly basis. There are 3.6 billion events that we're tracking on a monthly basis on average. This turns out to result in about 63 security alerts and 37 incidents that actually need follow-up. So I suppose the upshot is that, you know, this is a very worthwhile investment that we're making to make sure that we're keeping ourselves safe and we can keep our services running. We've also recently introduced quite a significant amount of automation to make sure that we can improve both the detection of these events and also the responses to them. So, you know, we've automated repetitive tasks, and we've also minimized all the manual workload associated with that. So, as I say, it continues to be a very valuable cross-system resource. Just to repeat, it doesn't just support the health organisations and providers, but it also supports both Staffordshire County Council as well as Stoke-on-Trent City Council. So I'm very happy to report back on that action, and we'll share that report on a periodic basis as it comes out, David.
Yeah, thanks very much, Chris, and a really important piece of assurance going forward. So I think those regular ongoing reports are necessary. Chris, if we could just make sure the action log is complete in the box with the summary that you've just given. And Julie, can I just check that that covers off that issue?
It does. It does, and I had a good conversation with Chris, so you know, I can give that assurance as well. I think the thing to just note is these threats are getting more sophisticated, so
Sure.
It's very real and present. But thank you.
Yeah, absolutely. Thank you, Julie. And Julie, the second point that you raised was about the palliative care arrangements. Becky, I know we have the update in the log. Do you want to add anything to the report that's there?
Not at this moment, David, because obviously the meeting where we were going to raise it is going ahead today, so I can't report back in terms of, you know, sort of the discussion that was held in there, but happy to do that offline, Julie, if that's useful.
Great, thank you, Becky. And Becky, when the meeting has taken place, if we could just make sure for the next board the action log is complete, so where everybody can see that the action has been closed down. That would be great. Okay, so that takes us to item 6. Any questions that we've had submitted from members of the public in advance of the meeting? And Tracy, I think I'm going to hand over to you to navigate us through those and the colleagues who'll be taking the responses.
Okay, thank you, Chair. The first one we had is from Hannah Weaver, who would like to ask the board, what difference is the consultation really likely to make to the Integrated Care Board's proposal to permanently close the Samuel Johnson and Stafford FMBUs, which are freestanding midwifery birthing units? And what reassurance can you give that it's simply not a paper exercise?
Okay, thank you for the question, Hannah. Becky, are you taking that?
I am, thank you, Chair. So, as you said, thank you for the question. I think we are really, really keen that we hear from our patient public-facing, you know, sort of bodies in terms of their concerns, in terms of their thoughts around the proposals that have been put through. Just want to be really clear that we have made no decision with regards to the future of either of the FMBUs. So the feedback that we do receive as part of the consultation is going to be really critical. And also to note that anything that comes back from feedback and any suggestions that are put through, we will also take into consideration as we push forward with regards to the consultation and the engagement events, and the outcome of that will be taken into consideration. I think the other area is that we have already liaised and engaged as we've developed this business case with the public and with the clinicians, and their views are continually to be sourced. So just to put that into a real context, no, there is no decision, and yes, it's really important that we get those views fed into our consultation as we go forward.
Thank you very much, Becky. Tracy?
Okay, thank you. So I'm moving on to questions we've now received from Mr. Ian Syme. The first one again is a maternity question, and he says Appendix A Quality and Safety Report states that the Section 29A warning notice and Section 31 notice of decision from 2023 Both still remain in place at university hospitals of Derby and Burton. Royal Wolverhampton Trust maternity services have now been rated good, whilst University Hospital North Midlands maternity services, previously rated inadequate, are now good, leapfrogging the CQC intermediate rating of requires improvement. The Section 29A notice served on UH&M November 2023 no longer applies. Having read through the University Hospitals of Derby and Burton board papers, I've noted plethora of external oversight of their maternity services. It appears, excuse me, that significant improvement of maternity services at University Hospitals Derby and Burton is seemingly more constrained in comparison to University Hospital of North Midlands. Is that analysis fair? And if so, what factors underlie the slower improvement of maternity services at University Hospitals Derby and Burton, given that Queen's Burton unit is the second busiest maternity service used by Staffordshire women and only superseded by University Hospitals North Midlands?
Thanks, Tracy. Ian, thank you very much for the question. Ian, I'll just alert you to the fact that it's a very detailed question, relevant question, but very detailed. We'll take an initial response and I'll be guided by the executive team if we may need to take any other soundings before we give a fuller response. Becky, are you picking that one up as well?
I am. Thank you, Chair. So thank you again for the question. As we've already highlighted, that's quite detailed, and I think there is an opportunity here for us to have that discussion outside of the board if you want further detail from the response that I'm going to give right now. I think it is a difficult one to try and compare UH&M's improvement alongside UHDB's. Even though they both had a Section 29A and a 31 from CQC, there are some variants between the two. In particular, you've got UHDB that's got 2 sites that are involved in their CQC review, and that adds another dimension, another complication in terms of trying to respond to the actions that have been required. We are aware that obviously UHDB were again re-inspected in December. We have yet to get that report from CQC, but we are also, sort of been insightful in terms of the assurance that's been given and the number of actions that have been undertaken by UHDB in answer to their initial Section 29A. I think there is also that part to play where we know that UHDB have asked for 6 of the 8 requirements that were placed on them to be reconsidered, and that again will be coming back from CQC following the evidence that they've submitted. So, so in answer to that one, it's difficult to make that comparison across the two because UH&M and UHDB have a whole set of independent responses required as part of their CQC report and review.
Thank you, Becky. Tracy?
Yes, okay, so the final question we received is again from Mr. Ian Syme, and it's about the Integrated Care Board local dental plan. Given the oral health profile in Stoke-on-Trent, it's understandable that Stoke-on-Trent is a significant priority area for dental service commissioning. What is somewhat surprising is that Staffordshire Moorlands area, population circa 95,000, with pockets of significant deprivation, is at this time not perceived as a priority area for dental service commissioning. Whilst appreciating that given stretched resources, not all areas can be designated priority, but what is the logic for Staffordshire Moorlands admission?
Thank you, Tracy. I'm just looking at the room. Paul, EJ, is this coming your way, yeah?
Yes, it is. Thank you, David. So thank you, Ian, for the question. What I'm going to do is to say the issue is going to be picked up specifically by the presenters when we do the local dental plan on the agenda. And I think that will answer Ian's question as we go through. And then we're happy to provide Ian with a full written answer afterwards, after the meeting, if that's all right.
Thank you, Paul. Tracy?
No further questions received prior to the board. Thank you, Chair.
Great. Thank you very much, Tracy, for that. And thank you for the 2 people that have submitted those questions. They're very welcome. And thank you for considering those points and submitting them. If we could move into item 7, enclosure 5, which is a very important item, a community story concerning prostate cancer awareness and the campaign that's driving that forward. And I understand I'm handing over to Phil Smith, who's going to introduce the team, who will then take us through the key elements of this item. Phil?
Yeah, thank you. Thanks for the opportunity to come and share the incredible work that's been done by the cancer team, led by Mark Duran and Jodie Furby, who are joining me today, who are part of the ICB Planned Care portfolio. It's really great to be able to talk through the value and difference in outcomes for the population that can be achieved through proactive and innovative approaches to early detection of cancers. We work closely, obviously, with the West Midlands Cancer Alliance to increase public awareness through a range of approaches, and Mark and Jodie will talk through how some of that has evolved. But for today, we're going to focus on our most recent awareness campaign around prostate cancer to showcase the impact and the learning from this targeted approach. So I'll hand over to Mark now.
Okay, welcome Mark and welcome Jodie.
Thank you very much, Chair. I appreciate that there are pressures on time, so I will dive straight in. So thank you for the first slide. Just by way of introduction, I'd like to advise the board that cancer as a function benefits from ring-fence funding at a national level via cancer alliances, and we're a very active part of the West Midlands Cancer Alliance. And in 2024-25, we were allocated a significant sum of money to promote awareness of cancer symptoms, and we ran 13 campaigns, approximately one a month with a slight variation. And we also held a 3-week cancer bus tour, which Jodie, my colleague, has led on. And once we've finished the initial part of the presentation, Jodie would be quite happy to expand if there are any questions or queries. But without further ado, I'd like to take one element of the prostate cancer campaign, Clifford's story, and share that with you. This is a relatively shortened version of the original. Thank you.
My name's Clifford John Hall, and I was diagnosed in April 2022. If you're having any symptoms of prostate cancer, please get advice immediately. If there's anybody in your family that's been diagnosed with prostate cancer, get it checked out. I do know that it's genetical, and that if anybody in your family has it, you need to get checked. And once you know, then you know. And if they catch it early, then it is treatable. But if you let it go too long, if you leave it, let it fester, then it will kill you. The sooner they catch it, the easier it is to cure it. There is so much I've got to look forward to. And I can do that now without the worry of prostate cancer.
Thank you very much. So if we can flip on to the next slide, thank you. I'm not going to attempt to read the content of this slide. It's some background information on prostate cancer. What I will say to the group is that the reason why the ICB has been seeking support from the Cancer Alliance to improve awareness of cancer symptoms across the board within Staffordshire and Stoke-on-Trent is that it is one of the biggest determinants of outcome. Although it varies from cancer type to cancer type, it is very clear that stage at diagnosis, in other words, how early the cancer has been found and whether it is spread or not, is one of the biggest determinants as to whether the patient has a good outcome and a long-term survival chance very high, or a poor outcome and a limited life expectancy. Even if we can make all of the services available to cancer patients absolutely state-of-the-art and world class, they only work for patients who present and walk through the door and report symptoms. And almost by definition, those cancer types that tend to have worse outcomes are those that present with difficult to recognise symptoms. Prostate in particular is prioritised because some of the symptoms in prostate cancer can be embarrassing to patients, and we are very clear that patients don't talk about cancer and cancer symptoms, so people don't talk to their peers, they don't talk to family members, to loved ones, and therefore they don't talk to their GPs. So as a result of that, we have got a significant ambition to improve cancer awareness and encourage patients to present to their GPs at the earliest possible stage. I will pause now in case there are any questions or queries about prostate cancer, and then if time allows, I'd be happy to share with you some of our plans in the future.
Okay, thank you, Mark. I'll just any questions specifically on that? If not, Mark, I suggest if you carry on to the next piece, and if people want to come back to a question on that at the end, let's do that.
Okay, thank you. So if we go on to the next slide, if that's okay. I'd like to ask my colleague Jodie, who is leading on both cancer awareness and our cancer bus tour, to summarise some of our plans for 25-26.
Yeah, thank you, Mark. So just reflected back to the cancer bus tour we did in March. We visited 15 locations across Staffordshire and Stoke, and we saw over 6,000 people. We've got fantastic success stories from this cancer bus. We've already booked it in now for March of 2026. So that's all prepaid with West Midlands Cancer Alliance funding. Of course, as well, we're going to be continuing with our targeted online campaign work. So again, we'll be hopefully looking at doing 13 campaigns over the course of the year. And with previous learnings, we want to do a lot more community engagement work with our voluntary sector colleagues as well, just to get into those communities and those that are suffering from health inequalities.
Thank you, David. Could we have the next slide, the last slide, please? So, ladies and gentlemen, board members, if you have any further questions or queries about the approaches and plans we have within the Planned Care Cancer and Diagnostics portfolio of the ICB, then our contact details are on screen. But for the remaining time, both Georgie and I are quite happy to take any questions or queries anybody might have now, or any comments or feedback. Thank you.
Yeah, Mark, thank you very much, and Jodie, for sharing that with us. A couple of quick points before I open it up for any wider discussion. I'd be grateful if you could thank Clifford for his powerful clip there and allowing us to share that at the board today. And secondly, just in the papers, I know the recommendation is that we're receiving this and noting the work to date, but there is quite a bit of work planned to actually broaden the scope of this, and as you and Jodie have indicated, to get more of this out into that neighbourhood and place locations. And that's certainly in line with what we're trying to do to get this front line early intervention for people to be able to access these services. So let's take a few comments. If I could go to the room first. Is that Paul?
It's Paul. Yeah, thanks David. Paul Brown. So I want to speak as a patient, not as a CFO on this one, because at the same time as Clifford, actually about the same time, I was diagnosed with prostate cancer, and I had no symptoms at all. It was down to this type of campaign that I went to the GP and had my PSA test. So to any men listening, yeah, get assessed, have a look at it, and I'm well and been treated. And like Clifford, I don't think I would have been had I not followed the advice of the campaign. Thank you, David.
Very powerful, and Paul, thank you for sharing that with us this afternoon. Peter.
It was very powerful, wasn't it? And thank you for doing that, Paul. Luke, first I want to say thank you to Mark and Jodie for all the work you've been doing. And of course, others, I'm sure you weren't the only drivers of the bus. Yeah, fantastic, absolutely fantastic. Second point is that this is kind of all what the left shift is about, really, isn't it? That fundamental move from reactive services to proactive and preventative services. So you've kind of showcased, what we need to be doing and focusing on more in the future. And then the final point is, I suppose, the link then through to, which I'll mention in my update in the Chair and CEO session in a bit, the cost reduction programme for ICBs. And Look, it's just as my gradual exit out of the ICB is in situ, as it were. It's a plea to the great and the good to ensure that we don't lose focus on these hugely important initiatives and make sure that, you know, they're front and centre of how we operate as an NHS going forward. So thank you, David. Thank you.
Thank you, Peter. Showkat?
Thanks, David, and thank you, Jodie, and thank you, Mark, for just highlighting the campaign. And the campaign is what I really wanted to talk about, because it's fantastic to see some of the work that's going on both online and I think the bus tour is a really good idea because it takes you out into communities and places where people naturally may not go online necessarily and do that. And I just wanted to unpick the campaign a little bit more, because when you read some of those statistics, particularly 1 in 4 Black men are more susceptible to this type of cancer. And then you look at some campaigns, you know, they go outside football grounds. I don't know whether that's been tried or not, like going outside Stoke City. I don't know what the attendance levels are like at Stoke, but again, sorry, I'm a Derby County fan, so I'm always going to have a bit of a bias towards Stoke as a football club. But you know, sort of going out there where you know that there are possibly thousands of people there in one go, and the footfall is there, using mosques on a Friday, you know, sort of reaching out in a way where, particularly where those hard to reach groups. So I don't know if that work has been done or not, but I think it would be great to see that within the campaign, alongside working with the voluntary sector, which I know you've already said, because it's about that outreach work, as David mentioned earlier, is critical to this kind of activity and campaign, and getting out there in communities where they won't just naturally go online or pick it up elsewhere. Thank you.
Thanks, Showkat. Julie?
Sorry, I couldn't come off mute then. Just a really great example, as everybody said, of Left Shift. I just wanted to ask very specifically how this has been integrated already within the community transformation programme for this year.
Okay. Peter, do you want to, or I don't know whether Elizabeth is on the call?
I can get on.
Yeah, sorry, could Elizabeth, that broke up a little bit on me, so I didn't hear the question.
Yeah. So Julie was asking how integrated this is into the transformation programme rather, for this year.
Yeah.
Community transformation.
Yeah. Elizabeth, if Elizabeth's in the room, she'll be best placed probably.
So I guess what I can say is, I wouldn't say, well, it depends which part. So the kind of premise of, can we provide preventative interventions that pick up disease sooner, as a general theme and point, yes, that is the principle of which we've been working, particularly in terms of that first part of understanding the opportunity to do that by looking at the data about our population. If it's, you know, the specifics around tests for earlier detection of cancer, that we haven't really got to that level of specificity, but the idea that we can use the data to identify, to be really honest, you know, low cost, could be frequently carried out interventions to detect disease earlier is part of what's being looked at. So I hope that answers the question.
Okay, thank you, Elizabeth. Okay.
Thank you. Mine's going to be a similar question to Julie, acknowledging what everyone has said, but specifically around mental health. As everyone who has attested has said, it's difficult anyway when you don't have that additional burden, but I imagine that this would be even more important for people with mental health diagnosis.
Thanks, Bucky. Joe?
Thank you. I suppose this touches a little bit on what Bucky said, but I think, you know, absolutely so important for our patients to know if they're symptomatic or if they're in a high risk group or high risk ethnicity, that they get tested. I suppose my question is you know, for the other group, the asymptomatic group, which Paul mentioned that's how his was picked up. I mean, PSA isn't national screening because of its sensitivity and specificity. I suppose my question to Mark and Becky is that, you know, this is targeted screening for high risk individuals, is that right? And, you know, has there been a piece looked at for the screening as such for asymptomatic individuals and the outcomes and the impacts of that? I mean, Bucky's mentioned sort of mental health, because I think, you know, if the test isn't sensitive enough, that itself can cause anxiety to groups of patients. Thank you.
Thanks, Joe. Mark, do you want to come back in on that specific point?
Gladly, yes. With respect to prostate cancer, there is not an accepted test that the National Screening Committee has authorised us to use for testing for prostate cancer. There's been a lot of media about this, and we got a lot of questions about this on the Cancer Bus. And in fact, the longer version of Clifford's video, he talks about PSA testing. And the board probably needs to be aware there is a slight disconnect between public expectation and what is technically possible. So there's a committee, a national committee, that reviews all cancer screening programs and proposals, and prostate cancer has been reviewed every year for many years. And at this point in time, the PSA test does not tick enough boxes to be justifiable as a blanket prostate cancer test. However, the good news is that there are multiple additional blood tests that are currently in clinical trials, and we expect there will be a suitable prostate cancer screening test coming along screen in the next few years. However, when it comes to cancer screening in general, Staffordshire and Stoke-on-Trent is one of the leading lights in the country for screening for lung cancer. And in fact, we are the most developed lung cancer screening programme in the West Midlands, and have probably 75% rollout across our patch, with the hope to move to 100% in the next 12 months. So we take asymptomatic screening very, very seriously. And one of the other campaigns we didn't attempt to talk about today, because we wanted to be focused on the prostate story, is we do promote attendance at cancer screening an awful lot, including getting people to opt in when they pass their age threshold, which is really important. And I'd be more than happy to share more information about what we're doing on cancer screening in more detail to any board members. I'm quite happy to share that. It's one of our key work streams.
Thanks, Mark. It might be something that we could pick up actually at a deep dive development session later in the year. Tracy, and then we'll
thank you, Chair.
We'll bring it to a conclusion.
I just think for completeness, because the public don't always have access to the chat. So just for completeness, Jodie had responded to Showkat's question, and they'd been to Port Vale, and they've got links with the local mosques and liaising with communities to have a stand on a Friday where they can share their campaigns. And Anna from Health Watch has also said she's attended the Cancer Buzz and seen it firsthand, and then looks keen to support in adverts. Just for completeness for people who are watching this, that was what's in the chat.
Okay, thank you very much, Tracy. So we'll bring that to a conclusion. Mark, Jodie, as Peter has already said, thank you very much for bringing this along today. Thank you for all the work and traction that you put behind it. Is that a bit of a pun, actually, with the bus involved, isn't it? But it seems a great initiative, and I have actually seen this vehicle on a Morrison's car park, actually. So it's great to see it out in the communities, and as Peter described, a really powerful example of what we're trying to do to push this sort of work down into place and community level. So I'm sure we'll come back to it, but for now, Mark, Jodie, thank you very much.
Thank you for the invite, and we hope to see you again soon.
Yeah, thank you very much.
Colleagues, we'll move into item 8, enclosure 6, if we can, the Chair and Chief Executive report. I've got a few things I just want to pick out if I can. And most importantly, and firstly, I just wanted to pay tribute to Peter Axon and Paul Brown. It is their last board meeting today. And guys, after decades of service in the NHS, both of you indicated me after the Christmas break, this is the problem when you let people take holidays, came back and said you were planning to move in different directions by the middle of the year. Both of you made an outstanding contribution to the service nationally, but also in terms of the service locally, and particularly the establishment of the Integrated Care Board. That gives a platform for where that goes into the future. So on behalf of all board members, and we'll get other opportunities to do this, I just wanted to put on record the board's thanks to both of you for all you've done. So thank you for that. And while I'm just in the position of thanking people, I wanted to note as well that David Wakefield, the chair of University Hospital Trust, steps down shortly in the next couple of weeks. David's been in the system, I think, now 7 years. I just wanted to thank David for being a great colleague across the piece. Jackie Small is stepping into that space as interim chair, as well as covering Midlands Partnership Trust, and look forward, obviously, to working further with Jackie in that role. Secondly, I just wanted to thank Alan White, the outgoing leader of Staffordshire County Council, for Alan's service and engagement with the ICB and ICP during his tenure, and wish him all the very best for the future. And I also want to extend a very warm welcome to Councillor Ian Cooper, who has been elected leader of Staffordshire County Council, and Councillor Cooper has already announced his cabinet, and I've written to him congratulating him on his election result, and we look forward to picking up engagement with Councillor Cooper in his leadership role going forward. Just moving on slightly, you'll note in the report there is a reference to the fit and proper person test. That's an important part of the governance that we undertake on board members, the due diligence around members who sit round this table. We're in the process of closing all of that down. The reason it's here today in a report is to signpost that we will return that to NHSE by the end of May, Tracy, and we will report it at the June board meeting, July board meeting, sorry, formally. So that will be in the formal public domain. And then finally, I just wanted to pick up on the ICB reform. A lot going on in that space. And Peter, I'd just be grateful if I can hand over to you to just give a quick resume of where you think we are with this very fast moving piece of work.
Yeah, thank you, David. Good afternoon all. So on the ICB cost reduction work, we are, and that's why in part executives are all together in a single room, you can see on screen. We're working at pace to get to the deadline, which is the 30th of May submission point, for a clear understanding of how we will achieve our cost reduction. So for those that aren't aware, that is a very precise number, £18.76. I think I've got the pennies right on that, per head of population, for every single ICB across the country. Now, for us, that is a circa 39% reduction in our cost base. And there's a clear acknowledgement that we can't do that in isolation, that level of cost reduction on top of the reductions previously expected of us, described and mandated by the Centre over recent years. So we've been working with colleagues across the West Midlands to understand how we can better come to that reduction level. There's kind of 2 or 3 ways that we're achieving that. So firstly, what I describe as vertical integration, which is working more closely with those within our current footprint. So that's predominantly, of course, our providers, all of which are in the room, but also local authorities, to understand how we can work better together, delivering economies of scale. Just by moving a service from one place to another isn't, by the way, a cost reduction, as you would imagine. We would need an economies of scale benefit associated with that cost move, but that is quite possible when it comes to that vertical integration piece. And then the other logical option is to horizontally integrate and link with other fellow organisations or the fellow ICBs, and there's a localised version of that, and that particular work is taking place with Shropshire, Telford and Wrekin. ICB. And then there's a broader version of that, which is coming together across the West Midlands footprint. I personally would say that we shouldn't rule out a wider Midlands option in terms of some of the services that we provide, but those conversations are ongoing with regional colleagues and wider ICB colleagues. So essentially through those three routes, vertical integration, horizontal integration at a micro level, and then at a macro level, we're looking to pull together a plan to achieve the £18.76 target. It is really tight, the timescales are. And once that initial hurdle is overcome, then of course there's a period of conversation with the regional and national team about essentially the achievability of that plan, and then if supported we'll be able to move forward, but all of that does need to happen quite quickly given the expectation that those cost reductions will be achieved by the end of Q3, the end of the calendar year. So in summary, a lot of work is happening very quickly, and we'll be able to give the board updates every time we meet in terms of this because of the level and rapidness of the work that's occurring. The other area I wanted to just briefly mention was the operating plan. And again, as you can imagine, a lot of work is occurring in that space. There is an item on the agenda to briefly update members on that. But suffice to say that the scale of the challenge, the scale of the ask that we have is significant, and therefore, of course, the task, the resource, the energy needed to put in to deliver against that is also very significant. And the final point I'd mention is, of course, the risk associated with delivering successfully one of those two agendas that I've just described. And I think the centre nationally as well as those locally are very aware of that risk. And just to give some assurance, we are in the process of creating a committee that will report through to the full board, that will oversee the risks and mitigations associated with failure, essentially, of either of those, so that transition process, and then that will be underpinned by working groups. So we're, as I say, very aware of the risk of being pulled into one and not being able to deliver both of those agendas. I'll stop there, David, if that's okay.
Thank you, Peter. Just pause if there are any questions from any board members on anything to do with the CEO chair report. Julie.
Not a question, really. I just think it's a very important meeting post the blueprint being made public, is the amount of work that's going on, but the amount of uncertainty that creates. And I think it's important for us to thank executive and all the staff involved for the professional way in which they're actually going about this really rapid piece of work, but also for the public. And Peter mentioned it, is we still are going, we have to have those 25-26 plan objectives have still got to be delivered, and services still need to be carried on, and to give that assurance to the public who are listening. But a very big thank you.
Yeah, well said, Julie. Thank you for that. So if no further comments, thank you, Peter. We will move on, if we can, to enclosure 7. Important item, the local dental plan. And Paul EJ, if I could hand over to you to introduce this.
Thank you, David. This is the local dental plan, which I know a number of people on here have been asking to see for some time. The purpose of the plan, of the paper today, is to update the board on the local dental plan and also to seek approval for it. If it's all right with you, Chair, I'm going to hand over to Sarah Jeffrey and Tracy Cox, who are both on the call, and they're going to take us through the paper and answer any questions.
Yeah, thank you, Paul. Welcome, colleagues.
Thank you, Paul, and thank you, Chair. And good afternoon, everyone. I'm Sarah Jeffrey, Director of Primary Care for the ICB. If I can just start by just giving you some statistics for Staffordshire and Stoke-on-Trent. So NHS dentistry from COVID, it's still not recovered 5 years on. The percentage of children that are accessing our dentistry services is only 51%. and adults is 43%. The percentage of children to have decay by the age of 5 is 25.7%, just specifically for us. And in some areas of Stoke-on-Trent, it's more than 50% of our children. General anaesthetic rate for 0 to 19-year-olds for extractions is 0.3 per 1,000 people. So in Staffordshire and Stoke-on-Trent, we also pay the lowest rates of pay for NHS dentistry, and that's the lowest in the whole country. And we've remained at the bottom for many years, meaning that recruitment and retention of dentists locally can be quite difficult. Our dental budget has also been hugely underspent for a number of years now. Hence, this is the right time for a really good plan. There are a number of things that we've been working on locally to improve our position. And one was our local dental health equity audit. And that's been undertaken by a consultant in dental public health. So what that pulled together was a kind of wide range of data, intelligence, as well as patient feedback. But that's then been used to prioritise that targeted action, improve access, and help to reduce those health inequalities. The audits also supported the identification of 12, and I'll call them initial priority areas, with the poorest oral health, and they also have the lowest levels of access of services in those 12 areas. So I do recognise that Mr. Simons asked a question specifically regarding Staffordshire Moorlands. So it's not to say that there won't be improvements within that area and investment, but the initial focus for health equity is on those 12 areas with the lowest levels of access and poorest oral health. So the list will continue into the future, and more will continue after those 12 initial areas. The aim is also to improve overall access to NHS dentistry across the whole of Staffordshire and Stoke, so not just those 12 areas, just hasten to add. The dental contract is quite complex. Patients don't actually register with an NHS dentist like they do with a GP practice. They can go anywhere in the country for NHS dentistry, so where that activity is available or where dentists are taking on patients, you can actually access that wherever you like. So we have also been able to increase our units of dental activity rates, so the rates of pay to local dentists, which brings us more in line with a West Midlands average. And that also means that we're more likely to recruit and retain dentists over a longer period of time locally to deliver that NHS activity. The other thing within the plan is the government wanted to ensure more urgent dentistry was made available. So as part of this increase, as part of this increase to our pay rates, we're ensuring that urgent dentistry appointments are allocated every single day. Patients will be able to access this by going through our advice line, a dental advice line, and they will direct patients to the nearest dentist with that availability on that day. So we will be ensuring that we have an appropriate communication campaign for our patients so that they know where they can access NHS dentistry. We're also investing more in our oral health improvement and prevention team, so supporting schools with teeth brushing techniques, particularly focusing on those areas of deprivation first, and more support for residents in our care homes as well. So I suppose finally, just to leave you with three things. Recruitment and retention of staff to work in NHS dentistry is one of the things we're focusing on, and making sure we have the right activity in the right place. The second thing is earlier prevention for younger people and support for older people. And the third thing is easier access for people in Staffordshire and Stoke-on-Trent to urgent care services without compromising routine activity. Just for clarity, Chair, this has been approved already through the joint commissioning arrangements of the West Midlands wide governance. So it's here today for ratification and support. Thank you.
Sarah, thank you very much for a very clear and comprehensive report there. And as you say, I'd noted from the recommendations there that it's already been approved, so we are formally noting it today. Josie.
Thank you, David, and thanks, Sarah, and thank you for the report. It's good to see that we are striving to make some progress in this area, although the statistics are quite shocking, really, aren't they, in terms of particularly young children and young people. I suppose my question is more about, you very briefly touched on communication with the general public, and I suppose it's about almost changing some people's mindsets in terms of what is available through NHS dentistry and what they can expect to receive. So I wondered if you could just touch a little bit more on what communication is going to be. There'll be many families that have never used NHS dentistry because they've never had access to it, and therefore they won't know or feel that that is there for them.
Thanks, Josie. Sarah?
So, and I can see Tracy and Adele on the call. We're working very closely with the communications team on communication channels that are relevant to our public, particularly focusing on those areas where we have, and some of our councillors describe them as dental deserts. So particularly those 12 areas, and reaching out to families in areas where they haven't been accessing dentistry. So there'll be a wider campaign, but we'll also be doing some focus pieces of work with those communities as well, Josie.
Thanks, Sarah. Showkat?
Thanks, David. Thanks, Sarah. And just really echo what Josie has said. I think this is hugely important, particularly in the context of some of the data and the numbers that you've presented. I was just a bit more interested in how the incentive scheme would work, the £20,000, and how are we going to make sure that, I assume it's not just sort of the introduction of more dentists, but also the retention as well, and people just don't end up taking the 20k, and then the issue still is there. And then the other piece linked to that was really about monitoring. So you've kind of set out those three key strands around access, prevention. And I think it would just be good to understand how we're going to monitor the plan itself, see what progress is being made. And I suppose if things aren't working, because, we have to try things, don't we? And absolutely, there's some really good recommendations there. But our ability to sort of pivot if we need to, if things aren't working the way we thought, and having those key performance indicators. Thank you.
Thanks, Showkat. Sarah?
So when you talked about the 20,000, Showkat, I'm assuming that you're referring to the Golden Hello scheme.
I am.
It is a national scheme. I don't believe it's going to be continuing into the future. It was it might have been a one-off. However, we have managed to attract dentists into those posts for Staffordshire and Stoke-on-Trent, and I'm sure Tony's going to want to come in on this, but I think the main thing is for our dentists locally is that by improving our local rates that we pay our dentists, their units of dental activity, that supports more of recruitment and retention within our dental practices. So I'll hand back to you for a second, David, in case you want to bring Tony in.
Yeah, I think we will, Sarah, at that point. Hi, Tony, welcome.
Hello there.
I would have been surprised if you hadn't have come in and asked a question on this item. So over to you, Tony.
No, I'm just hugely thankful and supportive of the work that the primary care team has been doing, and it really is, testament to the efforts in the background putting this plan together. And we are quite fortunate in that we've put this together locally within Staffordshire and Stoke-on-Trent, because I know some of the other regions are looking at some of the things that we're doing here and trying to replicate it in other parts of not just the Midlands but wider as well. Just addressing some of the points you mentioned there, Showcat. So yes, absolutely, the £20,000. It is a national scheme, but there are some caveats are built into it. So if the practitioners were to leave before the end of their period, there is conditions built into the scheme to ask for the money back. So don't worry, there are some built-in safeguards in there as well. And you mentioned about the recruitment and retention there, Sarah. Absolutely, one of the issues we have locally is there are areas where it's very hard, it's just not attractive to work in certain parts of Staffordshire and Stoke-on-Trent, purely because of what you've mentioned there about the very low UDA rates for some of the dentists, and this will make it much more attractive, and hopefully it will bring dentists in from other areas to work in our region, but also to keep them working there as well because of the disparity in the UDA rate. So I'm hugely thankful, and it's a great progress for what we've been doing locally and for our population.
Thanks, Tony. Okay, so Sarah will give you the last word, and then I think Tracy's popped in as well, and then we do need to bring it to a conclusion. Sarah rather.
Tracy may have wanted to come on and say, I was going to pick up on Showcat's second question around how do we monitor and report back. So do you want to answer that, Tracy?
Thank you, Sarah. Thank you, Chair. Yeah, so the dental plan is a very dynamic plan. So this is at a point in time, and what we want to really do is turn the tide on some of these numbers. We want to make these improvements. So we will be continuing to refresh our data, monitor this data, refresh our equity audit at a point in time as well. And I think it goes back to the question that Ian was asking. Actually, it is really important that we are making huge strides actually now on those kind of 12 priority areas. There will be work that happens in the background to continually refresh and ensure that our resources are pointing in the right places. So it was just to say that that is something that we will continue to monitor as part of this dynamic plan.
Tracy, thank you for that. It's a really good point to end on, actually, and I'm sure board members will want to keep this under close review because it is a real area of inequality throughout the area. So thank you for all the work. Thank you for working to pull the plan together. If we could just move to the recommendations. As Sarah said, the plan has been approved by the joint commissioning arrangements of the West Midlands ICB's Tier 1 Chief Executives Joint Commissioning Committee. So today we are endorsing and noting that, and have given our commitment to engage with the plan and the objectives contained therein. So if everybody's happy to do that, I'll thank Tracy, Sarah, Tony as well for involvement, and Paul for pulling this together. Thank you, guys. Okay, I'm aware we're probably 10 minutes behind the clock, but we'll move, if we can, into item 10, the National Planning Submission and Resubmission. And just before I hand over to Peter and Paul Brown to cover this off, I just wanted to go through a few key points from my perspective, which I think are important that we share in public today. Firstly, this planning round has been the most challenging that the system has experienced, I'd like to say, in living memory. It has been an incredibly challenging planning ground, and it's prompted much discussion and team working, and I'm very grateful that all partner members have engaged assertively and fully with the process. Local authority members in particular have recorded their concerns about the scale of the ask and have reinforced the requirements for effective impact assessments to be carried out. And I respect and acknowledge these points. The ongoing governance and scrutiny by the board and the executive will be critical if we are to safely land the plan. Following a full and robust discussion, the board formally approved and signed off the 25-26 system plan at its closed board meeting on the 25th of March. And as part of the submission of the plan and associated templates back to NHS England, it was recognised that further work would be required, particularly around ensuring that robust quality impact assessments have been completed. As a board, we've consistently reinforced that the quality and safety of our services is paramount and have taken steps to ensure that additional non-executive member scrutiny is deployed through our Quality and Safety Committee. Additionally, I've asked Julie Holder, our Senior Independent Director and Chair of Audit, to review the system board assurance framework and associated risk registers to ensure that they reflect the risks presented in the planning assumptions and manage them effectively. I've also asked Julie to consider the role of internal audit in providing added assurance around the delivery of the plan during the course of the year. We will also be working with NHS England to regularly review the safe delivery of that plan. Today, and I think this is key, that we are noting that the board has signed off the plan, which is financially balanced but contains significant risk. These risks will require forensic scrutiny throughout the year if we're to ensure that our objectives are delivered safely alongside financial delivery. So I just thought it was important from the closed section of the board and how we've got to where we are today with the plan. And the plan today contains additional assurances that have been put into the templates supporting the plan and are within the papers today. So Peter, with that said and that minuted background, what I'd like to do is hand over to you and for Paul Brown to bring forward any further escalations that are required at today's meeting.
Yeah, thank you, David. Look, that was a really thorough introduction, and I'm sure everyone appreciates that kind of transition narrative between discussions in the private board, albeit with this group, of course, but then bringing it into this more public forum. So thank you. Look, I'll be very brief and then hand over to Paul B by saying essentially what we've signed off is precisely that. It's a plan. So the work now, of course, and has been occurring for a number of weeks, is to convert that plan into very detailed deliverables, implementation, and changing how we work in certain ways. And of course, improving quality, improving that transition from reactive to proactive services, and delivering the money asked all at the same time. So from my perspective, I suppose the fundamental point being we were at a transition point when we signed off the plan a few weeks ago. We continue to do the work to get to full delivery. We're not there yet in many regards, but our ambition is very clear that we need to be there ASAP. And my hope and expectation is that we're doing that in an inclusive way across the system. Right, I'll hand over, Paul, if that's all right. I'll hand over to you in the room now to add to that as you wish.
Thanks, Peter. Paul?
Thanks both. And yeah, I definitely agree with that introductory, David. It was very helpful. And I'd like to add my thanks to colleagues from providers and local authorities, because it has been challenging, but we worked together really hard, and we did come up with a balanced plan, albeit accepting that, as Peter has said, has a huge amount of risk. But it was the latest I've ever known allocations to come out. It was 30th of January, sorry. All the work had to take place from that point on. We had a system, we called it a system lock-in in March, and colleagues from the executive teams across the system, including local authorities, joined that, and that was incredibly important. It was extremely difficult, but incredibly important in terms of coming together to do what we were asked, really, which is to come up with a plan which is within the resources, but also delivers on the major objectives that we were set. And those objectives are set out in your pack on page 55 of the pack. To reduce the time people wait for elective care, to improve waiting time for A&E and ambulances, to improve access to general practice and urgent dental care, which you've heard about, to improve mental health and learning disability care, and to do that within the budget, improving value for money, reducing waste, a collective focus on quality of service, to address inequalities and to make the shift from analogue to digital, So a very, very challenging ask that we were set. We believe we've done the best that we possibly can within the resources that we were given. As you said, David, the board have really agreed the plan. I mean, there's no fundamental change for us to make a resubmission. As you've said, that was really to clarify how we're going to deliver some of these asks. We haven't changed any of the asks at all from the plan that was approved by the board back at the back end of March. So in terms of finance, the headline number is a £306 million efficiency plan. That is almost 10% of our revenue resource limit. It is historically high. It is very, very challenging. But we did put in place, again, grateful to colleagues for working with us on this, a weekly process of executives coming together to look at building the plans. And we've seen the level of risk reduce as we've worked through those plans. Importantly, as you mentioned, David, with colleagues from local authorities in doing that work, making sure that this isn't about any degree of cost shunt, it's about making sure that what we do together is to make the healthcare better for our population, our residents, and I believe we are doing that. I particularly, so where we are now is working through all of those schemes, developing quality impact assessments for each one. We set a task to complete that work by the end of May, to sign off that work, and as you said at the start, David, there's an ongoing process with NHSE and regional colleagues to scrutinise that and check and make sure that the appropriate level of check and balances have been done around the QIAs, but also in terms of the delivery plans of those schemes. Headlines in terms of workforce are that there are planned to be reductions in the workforce. It's over 1,000 full-time equivalents, about 1,000, just short of 1,100. So it is quite significant. A large proportion, probably about half, is aimed at reducing agency and banks. So that's obviously a good thing, putting more of the focus into substantive workforce. But a challenging workforce plan. Also planned a challenging activity plan. We agreed as a system that we would plan for 3% increase of volume, recognising the growth of population and the additional, we heard earlier about access to cancer, etc. All those are additional patient contacts that we have to provide. And all the providers, including primary care, agreed to that principle of 3% extra workload for no extra money, which is effectively a very significant productivity gain that the system is planning to make. That has led to fundamentally to delivery of the compliance targets that have been set. You've seen that in the papers. That's across a whole range of different indicators. There's a few areas where we're slightly behind those, and those are listed in the report. And David, you mentioned the assurance process. The board took that job very, very seriously at the meeting you referenced, in terms of ensuring that the assurance was there, the right level of assurance, and that work is ongoing. So where we are, I think, is the best place that we could be, given the timescale and the challenge that we had. We have a balanced financial plan. We have the objectives of achieving all the major key targets, and we think we can do that. The plans are being scrutinised by the Finance and Planning Performance Committee, by Josie and other colleagues, and we continue in the work to ensure that the plan can be delivered safely, can be delivered whilst improving the quality to the residents and patients that we have within Staffordshire and Stoke-on-Trent. So the ask, as you said at the start, Chair, is for the formal public sign-off of the plan that we've already agreed as a board back in March. Thank you.
Thanks very much, Paul. And just going back to the points that you made there, I think as this moves forward, it's almost like every articulated piece needs to move forward together. So all of the quality oversight as well as the delivery needs to be sequenced, and the working of the subcommittees of the board actually really coordinated, wrapped around and supporting that delivery, or escalating where that delivery cannot be safely achieved. So just pause. Obviously, we had a very detailed closed section of the board where we went through the detail of the plan. If there's no further points, I'll just go to the recommendation, and we are being asked to formally note the formal sign-off by the closed board in May of the 25-26 plan, which is a financially balanced plan that's compliant on the majority of the national ambition and targets, and to note the refreshed assurance statements that will be returned to NHSE. So if everybody's happy to do that, we note that and we move into item 11 on the agenda, Enclosure 9, another very important report today, an update on the intensive and assertive community mental health care review. Elizabeth, I think I'm handing over to you, and then I think Nikki Bromwich is going to take us through just the key highlights of this report.
That's right, David. Thank you very much. Good afternoon, everybody. So just as a brief introduction and a reminder, so this is a report back on work that was instigated nationally following a CQC special review into mental health at mental health services at Nottingham Healthcare Foundation Trust. The ask was to ensure that there are clear policies and practice in place for patients with serious mental illness who require intensive community treatment and follow-up, but where engagement is a challenge. So the ICB has a coordination and a commissioning role here, and the board has had a paper previously related to the initial action plan that we submitted last year, and that came through the board in October of 2024. So we're back to the board today with an update in line with what is a national ask for every ICB board and every trust board to receive an update against the action plan. So as you say, Chair, I'm going to hand over to Nikki Bromwich, who's joined by colleagues from MPFT and North Staffordshire Combined Healthcare Trust. And obviously within the trust, they've been leading the implementation of the changes at service level. So I'm going to hand over to Nikki, and she, as I say, she's joined by colleagues who will be able to answer any questions that the board may have. Thank you.
Thank you, Elizabeth. So as Elizabeth sort of pointed out, this paper particularly provides an update on the plan that went to board, but also importantly, the 10 key recommendations for ICBs that came from the independent review into Valdo-Calcane's care and treatment. It also includes progress against those actions, and then again, the new actions that were picked up in terms of the Claire Murdoch letter and what is required to implement. I think what was really important for ourselves and the trusts was to really also set some of the wider national context to this, because there are a number of updated guidance that are directly impactful on this cohort that we really need to correlate and understand how we best meet the needs of this cohort moving forward. So in particular, as well as the independent review, in the independent review investigation, we wanted to bring your attention to the Staying Safe from Suicides, which requires trusts to implement kind of new risk assessment procedures. Also, there was a clinically led review of all the ICB plans, and that has come out with some recommendations in terms of good practice. There's been a series of webinars that have taken place that have really issued a number of guiding principles for what an intensive assertive outreach approach would look like. So they include things around key workers, really importantly around care and family engagement, and lots of other elements that are in there, and specifically multi-agency working. So there is also a key document out for consultation at the moment, which is around the personalised care framework. And this is around the standards that aim to guarantee that all individuals with a serious mental illness receive a minimum level of high quality personalised care and treatment, and that will be effectively organised and coordinated across multiple teams. So those are currently out to consultation at the moment, and they will need to inform our action plan and our actions going forward. And I think there has been a recognition that in the development of the community mental health framework originally, in the attempt to open up access, that actually we lost some of that governance around some of our individuals that, as Elizabeth has stated, need a different approach to ensure we maintain engagement with them.
So in terms of how we've approached this, both MPFT and Combined Healthcare have got task and finish groups in place, and have got a really strong organisational process within that, with their staff, with their workforce, and absolutely with people with lived experience as part of that. And again, we've used our engagement around the inpatient quality strategy to inform some of that as well. So the document really provides an update against the action plan. So I won't go through that in lots of detail, but it's just to recognise that obviously MPFT and Combined have slightly different starting points in terms of team. So Combined do have a very small intensive outreach team, and also have a multiple disadvantaged team that they are working with, whereas that isn't in place in terms of MPFT. So there are some differences there that you'll pick up, but on the whole, we've provided the update in terms of a system. We do want to bring your attention to obviously some of the aspects that are slightly delayed. So part of that is around the right care, right person planning. Obviously, we've had the National Partnership Agreement, and there are still ongoing conversations with Staffordshire Police and WOMAS and the Fire and Rescue Service around how we can continue to improve that response. So that is still an ongoing action. One of the things that was really clear from the latest guidance was that we needed to put on hold those actions that would require significant additional investment. And obviously we did submit an investment plan back to NHSE last year to inform future spending reviews, but at the moment those aspects are on hold. So really the next stage is for us to really consolidate some of that guidance that has come out. We'll wait for the consultation around the personalised care framework, and then we'll again adapt and reflect that within our plans. So that's just a very quick overview of where we are at the moment, Chair.
Yeah, Nikki, thank you very much for bringing this forward today. A really important report and an important part of learning going forward. Josie may be about to touch on this, but I was just going to ask, how's this going to feed into the assurance processes for the ICB and link in providers? Will that be through quality and safety?
Yes, so we've been to, as Josie will know, we've been to Quality and Safety Committee a few times now. We actually had a deep dive, was it March, I think, Josie, where we went through in quite a lot of detail, and obviously we commit to continue to do that throughout the year.
Thanks, Nikki. Josie?
Oh, thank you, David. Sorry. Yes, I was just about to sort of add a little bit more assurance to the presentation, to thank Nikki and provider colleagues, because I think it's been a couple of times you've been to Quality and Safety, and your memory, I think, is better than mine. I think it was March. You were quicker than me to remember that we did have a deep dive, and certainly there's, you know, the amount of work that has been the amount of work that's gone into this area is phenomenal, and great thanks to everybody. I suppose the question that I've got is more about the CQC role in all of this, because my understanding is, and tell me if I'm wrong because I may well not be completely up to date, is that the CQC are also going to start to come out and review teams, community mental health teams, etc., in light of obviously the changes that they believe need to be made, and how that sits with the business cases that were pushed back because there were no additional resources. How sort of confident are we that we are the best place that we can be?
Thanks, Josie. Nikki?
So you're absolutely right. I think the national team essentially are correlating all of that information at the moment in terms of what all systems have said that they need to deliver to make sure that this cohort of patients is effectively cared for. And it will require a different approach, and we have to be really clear about that. The approach that's required around engagement with family and carers is something that's on a different level as well. So I think these individuals are still our responsibility, and we still have to care for them now. It's just obviously how we would like to care for them in the future requires that additional enhancement. So I think some of that is still to be determined, Josie, in terms of what that future model could look like. But we continually look at where we can improve within the resources that we currently have.
Thanks, Nikki. And I guess, Josie, again, coming through the respective committees of the board just to make sure that this, is front and centre in terms of oversight going forward.
So may I come back, Dave? I guess
that's
kind of where I was coming from, really, in that we know that we've been told there's no additional resource at this point. I accept, Nikki, that things may change, but we can't lose sight of how important this work is and the broader mental health agenda. Given some of the issues that we need to tackle. Yeah. So I just wanted to make sure that we don't forget, really.
Yeah,
absolutely. Thanks, Josie. And it may be in due course that an assessment for, again, risk registers, etc., be made for inclusion. Showcat.
Thanks, David. Nikki, it's just a really small point, and it's really presentational more than anything else. So with the action plan, you've got the short, long and medium term list of actions. I think some of those, it would just be good to see. Some have dates, some don't. And there is, with some, I think there is an element of data, in terms of numbers, how much from, for example, training, how many people are expected to go through that. But I think it would be good to see that in a future report, just to have those things captured. And in some things there are timescales, with other things there aren't. And it was just that from a presentation point of view.
Okay. Yeah. Thanks, Showcat. Nikki, noted yet for next time. Thank you. Okay, so in terms of recommendations, we've got 3. Firstly, to note the assurance provided from the updates to the October 2024 action plan and review undertaken against the independent report on VC's care and update against those actions. Secondly, to note the requirement to correlate a range of recent and emerging guidance in relation to patient cohorts that require an intensive and assertive approach. And thirdly, to note the regional NHSE teams will work with all systems to review progress against local action plans in June 25 and January 26 and report back to the national team. So if the board is content, we will happily agree to those recommendations and look forward, Nikki, to that governance network coming back to the board in terms of how these recommendations are taken forward, or risks managed, mitigated or identified. Okay, thank you. If we could move into item 12, enclosure 10. Becky, I'll ask you to introduce the quality and safety report, and then Josie, at enclosure 11, we've got your escalation report. So if I can hand over to you, Becky.
Thank you, Chair. So within our report, we've already highlighted the CQC improvements against UHNM, which was significant. They received a good rating, and all of the Section 29A warning notice requirements have been lifted. As I said earlier, UHDB were also inspected in December of last year, and the outcome report is still pending with regards to that one. Other factors and other places of good report were MPFT. They have their working age adult and psychiatric intensive care unit re-inspected, and again they received good ratings by CQC overall. The paper also references the continuation of the home and host pilot, which has been rolled out across the ICS with support from key stakeholders. And we are aware that 2 hospitals have been opened within Staffordshire and Stoke-on-Trent, which it's hoped will support the ambition to place patients within that 50-mile radius of their home. We currently have a compliance of 83%. Following the implementation of the plans set to reduce the number of people waiting for wheelchair services, we have undertaken routine quality visits with progress being monitored. And whilst we can see there's continued improvement over the last 2 months with that waiting list, last 10 months of that waiting list, work is still required to strengthen the approach towards ensuring patients are waiting well. And there are further meetings that are planned with the provider to continue that discussion.
Lastly, there are reference to the paediatric hearing programme, which is an improvement programme at a national level. Work is still undergoing with regards to achieving the targets that have been set in the delivery of those improvements across both MPFT and UHM services, with UHM taking a look back exercise that was part of the requirement. That has now been commissioned, and we anticipate that we'll have the outputs of that review probably towards the end of Q2, Q3. And lastly, in that report is reference to the QIA process. We've already touched on that in the discussions that have gone before, but it's just indicating the alignment that we've got and the close working that we're undertaking with the Efficiency Working Group and also Finance and Performance Committee. That was a whistle stop, Chair, hoping that I've covered all the pertinent points.
You have. Thank you very much, Becky, and thank you for just alerting the board again to 5.1 and 5.2 in your report around the quality impact assessments, because you're absolutely right. That demonstrates very clearly what we are trying to achieve with that alignment and the scrutiny and oversight that we discussed during the discussion around 25-26 plan. Josie.
You've touched on what I was going to touch on, David, but I just wanted to mention in the papers on page 84, page 5 of this report, it talks about the QIA process coming to the QST triannually, and we're due that back again in June. We will be having a conversation about what that might look like given where we find ourselves this year, and it may be that process in terms of reporting through QST, I say it may be, it's not my sole decision, but I would imagine that would look different going forward from June in terms of more scrutiny.
Yeah, thanks, Josie. Again, very, very helpful signal that we do need to continually review and reinvent our processes in light of experience as we go through the challenges that we set out earlier in this board meeting. So, Josie, can I ask you just to pull out any exceptions from your AAA report, please?
Thank you, David. And Becky's picked up a couple of them, so I'll take the report as read. There's just a couple of things I want to raise, and then I'll draw the board to section 4, which is the escalations and the agreements that we need to report through. So I just wanted on the first page of the report to advise about the infectious disease response commissioning guidance for ICBs. There's a lot of work going on in this regard at the moment. There are a number of we did a gap analysis has been done, but there are still some risks that need to be managed. So in light of this, that work will come back to the committee in 6 months' time to ensure we've got full assurance that we are where we need to be. In terms of assure from the report, as I say, Becky's touched on a couple, but I'll just pick out one or two others. All age continuing care, we received the final report from the transition from the CSU into the ICB, and delighted that process went extremely well, and people seem to be settling in very well, and everybody was very pleased with how that had all gone. And sorry, I can't turn the pages quick enough. And Becky's already talked about the national hearing work, which I think is fantastic. And considering now that I believe, Becky, we are compliant with where we need to be with the targets. And I know further work needs to be done, but that is excellent. So in terms of a couple of items that we actually approved, we approved the mental health and learning disability and autism host home commissioning standard operating procedure, and we endorsed the Staffordshire and Stoke-on-Trent alcohol strategy. Thank you, David.
Thank you, Josie. Again, very clear report. So if everybody is happy to receive the reports, key quality assurance and patient safety activity undertaken in respect of matters relevant to all parts of the integrated care system. We'll move into its sister report, the Senate report, item 13, enclosures 12A and 12B, two AAA reports. Paul E.J., I think you're taking this on behalf of Rachel Gallio.
Yes, I am, please, David. Obviously, Rachel chairs the Health and Care Senate for the system, but I'm just going to present the two today. I'm going to take both of them as read. Just to highlight, on the one of the 13th of March, which is 12A, There's a summary from IMOG, which is our Medicines Management Committee, and there are some technical items on there for noting. The second one on that first one is the approval of the gynecology pathway for the system, which is an important document for our women's health strategy. And then the third one, again, really important for the way that we all work together, is the all-age palliative care and end-of-life strategy, which is quite an extensive document. There are quite a number of delivery objectives in there and a lot of work for people to do together to actually take this forward and bring that to life. So those were the three things on the 13th of March. 10th of April, again, there's the IMOG report from a month earlier, which has got a number of technical things on there again. The second one on there is the earwax removal policy. This is a really important one. This is a decommissioning policy, a review of...
Or we're just losing you a little bit on the audio. Yeah, I think we.
Sorry,
Paul, we
lost.
Yeah, if you back, Paul, we lost that part of the report.
Yeah, so the second part of that report was the earwax removal policy. This is an important document because it's a decommissioning policy. A review of this process showed that there was either limited or no clinical value, with some exceptions which are noted in the report around maybe people with learning difficulty and some older people who are on an existing auditory pathway. And then the final one, which again is important for the work that we do, is around the IFR policy, the individual funding request policy. And that was just an updating and a little bit of a tightening of the policy just to make it absolutely clear what could go through IFR and what couldn't, and how we applied the policy. They're there really for noting and approval, David. I'm happy to take any questions.
Great, thank you, Paul, very much, and thank Rachel for the work of the Senate in that period. So if there's no questions on the report, we're receiving and noting the March 13th report and the April 10th report. The board's happy to do that. We will, and move straight into item 14, the finance and performance report. We'll deal with enclosure 13 first, and then I think, Josie, you're on twice with 14 and 15 for AAA reports. So Paul Brown, if I hand over to you, and then Phil Smith, and then back to Josie.
Okay, thanks, David. Not much to say on the finance. This is now obviously quite retrospective. We're looking at month 12, the year end, and we're underway with the audits on that. It was, as the board knows, a really challenging year, but I think at the end of the year, relatively successful in that we got to the control total that was agreed with the regional team of 17 million deficit. I think I would just like to briefly say, David, just call out really the work that was done on continuing healthcare, because I think that was a real success, and credit to Heather Johnson, Claire Underwood, and also thanks to Neil Carr for his support and the support of his people into the system collaborative. It was really successful because it saved money, and that's obviously kind of my job. But I think probably more importantly, when we set out on this one, we wanted to test the hypothesis that if we could reduce the spend on continuing healthcare, we could also make lives better for our people, our patients, and that has been proven to be the case, David. I think we've got quite a bit of evidence now that your patients have got better lives as a result of having less intrusive packages of care, which obviously also save money. So it's a real success, which carries forward into the new year. But in summary, we had a difficult year, but we saw a strong second half, and we hit the control total, and in that sense, a positive end to the year, David.
Thank you very much, Paul. Time for a quick breath and then straight into this year with that. So any questions on the money before I bring Phil in just on the performance? Okay, I think, as you say, Paul, I think that's been pretty well rehearsed. So, Paul, Phil, can I bring you in on the performance escalation?
Yes, absolutely. Thank you. So March saw a continuation of pressures around urgent and emergency care. And I think it's really important for us to note that demand for the month was the highest volume in a month that we've seen since pre-pandemic. This has settled somewhat as we've gone into the new financial year, but obviously merits further analysis. Nationally, there was an increase in March and across the Midlands and Lancashire providers, which our CSU looked to, they can see data for 37 out of 39 providers saw a similar increase in March. We're looking into it, we're going to report back to System Performance Group, but at this point there's no clear driving reason for that. Increases across both walk-ins and ambulances, all acuity levels, across all symptom groups, and also seen across 111 and WMAS demand too. Despite the increases though, by the time we've got into April, proportion of our patients admitted, transferred or discharged in line with the 4-hour target has improved and was marginally above where we set out to be for month 1, but clearly we've still got significant challenges, particularly in terms of ambulance response times and handover times, with UHM in particular struggling with an average handover of 1 hour 32 in April. So clearly a very steep improvement trajectory for this year to meet the operational planning asks, which aligns to the operational plan set out earlier on. Key to feeding into how we work this year is obviously the learning from last year, and we held a learning event earlier this week, bringing all partners together. Patient and quality focus absolutely at the heart of it. We have patient stories, harm reviews within there, looked at local and national data, and a particular focus around critical incidents and the learning from those as well. That will report through to Finance Performance Committee and then ultimately through to board in a couple of months. Just from a planned care perspective, I previously reported the impact in terms of planned care procedures due to the UEC pressures. So although our activity has now resumed, the impact continues to be felt. We'd aimed to eliminate 65-week waits by the end of March, but we ended the year with 233. Obviously, this is an area with moving goalposts, as ultimately we try and get back to an 18-week standard, but it is important to stand back. In annual terms, we ended the last financial year with 10,000 less people on the waiting list across our population, so we've made real inroads there, and a reduction of almost 1,000 in those waiting over 65 weeks. So the plan for this year, as we've set out within the operational planning detail that Paul has done earlier, is to clear those 65-week waits, which we're looking to do by July. And I'm pleased to say that we're currently ahead of plan in terms of the reduction around 52 weeks as well. So I think there is some positivity there, but we've absolutely got to focus on getting that productivity through, maximum throughput through, particularly during the summer months before we head into winter again. Thank you.
Yeah, absolutely, Phil. That's a really important point you just made there, finishing that, we really keep the traction going during that period. So just pause, are there any points from the board to Paul or to Phil? If not, Josie, can I move into your AAA reports, please, for the April and May meetings?
Thank you, David, and I'll take the reports as read, and obviously from a finance point of view they are looking back over years that have finished, so I'll probably just want to say a few words about where we find ourselves now and what we need to focus on going forward. So we've already rehearsed a couple of times during this meeting the overarching financial and efficiency figures in the plan are going to be a real challenge, and coupled with the workforce reduction as a committee, obviously we are concerned that we get full assurance in terms of the progress of that plan and where we are, and early sight of any risks and issues. In June's meeting, we'll get a better understanding of the delivery trajectories and phasing, and so we can discuss the risk issues in a little bit more detail. But I just wanted to assure the board that we are very cognizant of the risks, and we of course will keep the board fully updated. Notwithstanding this, the risks and the pressures, we will need to ensure we've got momentum going forward and be clear in our expectations for delivery. So it's that balance between between risk and delivery and momentum that we're trying to balance in really quite delicately. In terms of performance, in May's meeting, we slightly changed our approach to how we look at performance. Some of you will know that it's a group that sits below finance and performance called the System Performance Group, which is a very high level group of the Chief Finance Officers, delivery and operational directors, etc. And so what we're now getting is a formal assurance report from that group, which you will see the output of outlined in the papers. And I think that helps us to actually focus in much more detail on the areas of concern rather than look broadly at performance. There was one escalation from that report last time. It's on page 127 of the pack, or page 2 of May's AAA report, which is regarding mental health and access to wait for autism assessments, and SPG are going to look at that in more detail and bring a report back to finance and performance in due course. And finally, I'll just draw your attention to sorry, I've lost my paper. I really have got too much paper here, David, today. I'm going to have to go digital. I'll go digital. I would draw the board's attention to a couple of policies that we approve. We approved the mental health assessment payment policy in the May's meeting, and we also supported a business case to be put forward to the West Midlands CAMS provider collaborative around supporting children and young people in challenging behaviour. That case will go, as I say, to the West Midlands CAMS provider collaborative. Thank you.
Thank you, Josie. Again, very full reports, and just thought reading the papers last week, the AAA reporting, it really collapses down the narrative in the report and makes it clearer. So thank you very much for that. Just pause again if there's any points of clarification. Okay, if not, so we're noting the high-level performance against the 5 priorities, acknowledging the high-level key programme deliverables and acknowledging the financial position. And we're also receiving and noting the Chair's reports for April the 1st and May the 15th to note. So thank you again, Josie, for that. So if we could move into item 15, we've got enclosure 16. Mish, I'm assuming you're on the call. And then Showkat, if I could ask you to take enclosure 17, your escalation Chair's report.
Thank you, Chair. So in terms of the workforce report, I will take the papers as read. The key highlights are that at the end of the financial year, the system did report a position of 1,271 over our operational planning figure. This is broken down by 880 more substantive colleagues than we'd expected to see. And although there was less agency, and the agency figure was only 1.6 against a target of 3.2%, these are really significant numbers for us. And I think we've articulated throughout this conversation the need to be very clear in terms of our assurance processes, and also in relation to articulating our CIP programmes, the risk involved in delivery of them, but also the workforce numbers, areas and deployment of workforce that will enable them to be delivered safely. So what we have done is work with our finance colleagues in the provider organisations to really change the process that we are using in terms of assurance of this. So both proactively and reactively being able to understand any reason for variance. So where are we going to see that? Is that because of new business, activity, acuity? Is it because of non-delivery of SIP programmes, winter, sickness, etc., which is some of the reasons that are articulated in the report by provider. We need to have really clearly financially linked data so that the workforce information is tracked back to SIP programmes and any other reasons for variance. So those actions are being taken through the PCI and also the Finance and Performance Committee. I think that's all from me, David. Unless there's any questions, I'll hand to Showkat.
Yeah, thanks very much, Mish. Very clear. We'll take Showkat's AAA report and then pick up any questions in a moment. Showkat?
Yeah, thank you, David, and thank you, Mish. And Chair, I probably don't want to say too much because I think Mish has probably covered the bit around what is for escalation, which is around the workforce growth, and the mitigations, as Mish has set out. It is about looking at those variations, closely monitoring the data and understanding what, where, why those variations are. And we'll continue to do that at People, Culture and Inclusion Committee and bring back to the board more detailed feedback around that. Thank you, Chair.
Thank you, Showkat. So just pause in case there's any points of any clarification. If not, thank you both. We note the workforce position, operating plan year-end position, and receive Showkat's Chair's AAA report. Item 16, enclosure 18, is the AAA report for the Strategic Commissioning and Transformation Committee. Mike Lawton is on holiday, so Julie, I take it you're stepping in for Mike.
Yeah, that's correct. Yes, I chaired on behalf of Mike. Really good discussion around NHS Reset, which was led by Elizabeth. Thanks very much for that. The role of this committee, I'll take the report as read, and a lot of which we've covered in the board today. The role of this committee is increasingly important in the future as we get further guidance around strategic commissioning for outcomes. We'll also need to be mindful, I think, as we go forward about the interface between the Strategic Commissioning Transformation Committee and the Transition Committee. I think we just need to be mindful of how they might cut across each other. Other than that, I'll take the report as read.
Thank you very much, Julie. Any comments? Clear report again. Thank you, Julie. Very clear. We receive a note. And Julie, you're on again. Item 17, enclosure 19, the Chair's report for Audit Committee.
Yeah, thank you. This was an extraordinary meeting of the Audit Committee. Again, I'll take the report as read. We met to do three things. The first one was to approve the submission of the draft annual report and accounts. We also received the positive outcome of the audit by Grant Thornton on the 23-24 mental health investment standard. That was positive. And we also agreed the 25-26 internal audit plan, although we'll need to review this in the light of your earlier comments, David, and how you've spoken to me around the assurance of processes to support the delivery of the 25-26 plan. Yeah. As far as the draft annual report and accounts is concerned, there's nothing to alert the board to at this point going out to audit now. But what I would like to do is to acknowledge and thank all those involved in the production of what really is an excellent report and document, and it was produced in very tight timescales. So a very big thank you to everybody.
Julie, thank you for that and all the work that's been done there. Just pause again. No clarification on Julie's report, so we receive a note. And Showkat, if we could just pick up item 18, enclosure 20, the Remuneration Committee report.
Yeah, thank you, Chair. Yeah, I think it's fairly self-explanatory. It's the appointment of the ratification of the appointment of the Chief Finance Officer for an interim period. There's not much more to add than that, Chair. Thank
you very much, Showkat. We receive a note. Items notified in terms of any other business. I've had none raised with me in advance. Any mission critical, any other business anybody wishes to raise? No. Okay, thank you. So that takes us to item 20, questions from any member of the public joining us today on any items that we've covered on today's agenda. So over to you. Okay. Ian, welcome.
Thank you, Chair. An observation first, please, if that's okay with you.
Certainly.
National planning resubmissions, obviously a note what you stated at the beginning of that agenda item. I think I expressed my concerns, and I know it's others' concerns with the reorganisation proposed for ICBs. I'm still mystified as to the reasons behind this, and obviously you have to do what you have to do, but I think we've been going in that initiative is going in the wrong direction, but let's see how it pans out. Question, if I can, please. It's regarding funding for next year. There have been reports about the national initiatives, SDF monies, being cut. NHS England, these are ring fence monies for national initiatives. NHS England said the majority of the monies will go into the core budget of ICBs. A, is that correct? B, I understand that a lot of the SDF monies, which were previously ring-fenced, service development funds, these are previously ring-fenced, will not be ring-fenced. So are the risks to the ICB and or providers with the change in status of SDF monies?
Thanks very much for the question, Ian. I think Paul Brown is probably going to take your question now.
Yeah, thanks, Ian. Yeah, you're right to raise this. SDF funding broadly in the similar lines this year to last, actually, but most of it is from last year was actually allocated out and is now being spent on people and services. So we've obviously continued with those. There was a small amount of SDF around the margins, really, sort of 2-3 million in total that we had some flexibility over, which we have played into the plan, but in the main we've used SDF in the ways that we had in previous years.
Thanks, Paul. Ian?
Okay, right. Can I pass on my personal thanks to Peter Axon and Paul Brown? I have followed NHS organisations since 1997. Board meetings, combined healthcare, what is now UHM, CCGs, BCTs, Strategic Health Authority, Staffordshire and Shropshire Health Authority, etc., etc. I followed you. I first attended one of your board meetings when you were in shadow, when you were a shadow ICB. I have already stated that the impact of the ICB and the improvements that you have instigated working with your teams has been quite astonishing. I know how difficult it is to get organisations working in concert, and obviously personalities working in concert. I would like to thank Peter and Paul for the service. I know you will talk about the work they've done within the ICB. I'm talking about the service to the general public. I'm really grateful. I wish you all well for the future. And again, my thanks.
Well put, Ian, and echoed by everybody around the board.
You have a very good team there, David, Peter. Thank you very much.
Thank you very much for that, Ian.
Yeah, thank you.
Okay, can I check, are there any further questions from anybody who's joined us? So, Tracy, can I just come to you? You may have picked up a question online or in the chat.
No, there's no further questions online.
Thank you. So just check with the room, Paul B and everybody. Legacy hand, I take it that's up. Yeah. Yeah, somebody's going to the machine to take that down. So just in terms of meeting effectiveness, we've covered a lot of ground this afternoon, some really important issues. Grateful to everybody for their preparation and for the reports that we've received, and particularly the team from the cancer screening team that came along to present to us. And just like to check that everybody feels we've adhered to the leadership compact. Certainly feels like it this afternoon. So we'll bring the meeting to a close. The date and time of our next meeting is Thursday, the 17th of July, between 1 p.m. and 3:30 p.m. And grateful to Neil Carr for arranging for us to use St George's site at Midlands Partnership NHS Foundation Trust, and we will be in person on that day. So thank you everybody who's joined us from the general public for your interest and engagement this afternoon, and thanks to all the board members. We'll bring the meeting to a close at that point.
Thank you.
Thank you, David.
Thanks.
Thank you, everyone.
Thanks, David. Bye. Bye.